Hi everybody, welcome to our Next Gen NCLEX review. We're so glad you guys are here. Happy Tuesday. We're going to make sure we're up and running on all of our social media channels, but hello to everyone on Facebook, TikTok, Instagram, YouTube. We're so glad you guys are here. We have a full session of information to cover, so we will keep our beginning stuff short and we'll get started in just a second once I get our green light from everybody. But happy Tuesday. All right, I think we are good to go. Oh, one more second. Just a quick reminder, we're here Tuesdays and Thursdays at noon Central Time. We're covering calcium and magnesium today. On Thursday, we're going to be covering sodium and talking about diabetes insipidus and SIADH, or syndrome of inappropriate anti-diuretic hormone, the longest disease process ever invented. But okay, I got the green light. We're good to go, so we will officially start. But hello again, everyone. My name is Jackie. I am a nurse here at UWorld. I'm so glad you guys all joined today to our free Next Gen NCLEX review session. We're going to be talking about calcium and magnesium today. We have a lot of information to cover, so we're definitely going to kind of get started right now. But I want to say a quick thing to all of our friends on TikTok. If you guys don't mind, go ahead and share that you are on this live right now so that all of your friends can join. The more the merrier. We want to reach as many nursing students as possible. So please share us. Let your friends know that you're on this and we can all learn together. Again, a quick refresher on our schedule. We're here Tuesdays and Thursdays at noon Central Time. You can find us on your favorite social media channel. We're on demand on Facebook and YouTube, so you can go back and watch anything you might have missed. Again, today we're continuing our discussion on electrolytes. We'll be covering calcium and magnesium. We're going to have a question at the end. And then Thursday, again, we're talking about sodium. We'll talk about DI and SIADH. And as always, use that chat function. Let us know any questions you have, any content you want to see. Let us know how we're doing. We love hearing from all of you guys. So make sure and let us know. Okay, so again, we are going to be covering calcium and magnesium today. And I have like a little bonus of phosphorus in there too, because it kind of sneaks in with calcium, but that's really what we're going to be covering. And then as a reminder, we covered potassium on our April 4th session. So if you want to go back and look at that, you can have a pretty comprehensive overview of all the major electrolytes. And again, that's on Facebook and YouTube. And then, yeah, so by the end of the week, we'll have really covered kind of all the big heavy hitters of electrolytes. So we hope that can help you guys in nursing school and on your NCLEX. So make sure and reference these as you need them. Okay, we're just going to jump in. We're going to do it. We're going to start with calcium. So we're going to cover calcium first, magnesium second, and we're going to start with hypercalcemia, then hypocalcemia. Okay, so calcium. Let's start with some basics. So calcium is an important electrolyte for a lot of reasons, but when you hear calcium, I want you to think of contraction, like muscle contraction, and specifically cardiac muscle contraction. So calcium contraction. The other basics that we need to know about calcium is like how it moves through our body. So it's absorbed in our GI tract, it's stored in our bones, and then it's eliminated through our kidneys. So we're going to cover just some basics too on some hormones that influence calcium. And we're going to use this kind of as our foundation just to go through the rest of our content today. So we have a little picture that we're going to bring up of our parathyroid and thyroid gland. So the first hormone we're going to talk about is parathyroid hormone. So parathyroid hormone is released by, you probably guessed it, the parathyroid gland, which are 4 small glands located on the back of our thyroid. So they're super tiny but super important. So parathyroid hormone is really what's responsible for increasing our serum calcium levels. So again, parathyroid hormone works indirectly on serum calcium levels by increasing osteoclast activity. So a reminder about what osteoclasts do. They are responsible for breaking down bone and releasing calcium into the bloodstream. So parathyroid hormone also increases calcium absorption in the GI tract. So not only is it going to increase calcium from our bones, it's going to increase calcium that's absorbed in our GI tract, and it's also going to work in the kidneys and reabsorb calcium that's getting ready to be eliminated. So it works in our bones, our GI tract, and our GU tract and our kidneys. So again, quick summary, parathyroid hormone is responsible for increasing serum calcium levels by releasing calcium from bones through osteoclast activity, soaking up more from our GI tract and putting it back in our bloodstream, and holding on to more calcium from our kidneys. So that's parathyroid hormone. The other hormone is calcitonin. So calcitonin is kind of the opposite of parathyroid hormone. Since parathyroid hormone is going to increase serum calcium levels, calcitonin is going to decrease serum calcium levels. So calcitonin is released by the thyroid gland, and it's going to cause us to reabsorb calcium into our bones, decrease the amount we absorb through our GI tract, and increase elimination of calcium through our kidneys. So again, quick recap, first recap of the day, parathyroid hormone increases serum calcium, more parathyroid hormone, more calcium, and calcitonin decreases serum calcium levels. So more calcitonin, less calcium. Okay, so let's talk about increased serum calcium or hypercalcemia, which is really what hypercalcemia means, increased calcium in our blood. Okay, so hypercalcemia, again, means increased serum calcium. It's typically levels greater than 10.5 milligrams per deciliter or 2.62 millimoles per liter. So what can cause this? Calcium rises from any change along that pathway that we talked about. So how calcium travels through our body, any change of that can affect how the calcium levels in our blood. So, it's absorbed again in our GI tract. It's stored in our bones, excreted through our kidneys. So if we have increased absorption of calcium in the gut from excessive oral intake of calcium and vitamin D, we can have hypercalcemia. So you might be wondering about vitamin D. Vitamin D is really what helps us absorb calcium from our diet. So increased absorption of calcium from increased intake of vitamin D. We can have decreased calcium excretion in our kidneys as another cause. So think kidney disease. When our kidneys can't filter our blood very well, we're going to have high levels of electrolytes. So we can also get it from medications like thiazide diuretics, which those types of diuretics help us reabsorb calcium in our kidneys. So we can have increased absorption from increased intake, and we can have decreased excretion from our kidneys, all of that leading into our final kind of element here about the pathway, which is increased bone resorption. So not reabsorption, resorption. So resorption is the process of bone breaking down and building back up. So since we know calcium is stored in the bones, resorption can lead to excess calcium being given off into the bloodstream. So again, we've covered our calcium pathway. Let's talk about conditions that can cause hypercalcemia. So let's remember back to a couple minutes ago when we talked about hormones that influence calcium. We learned that parathyroid hormone and calcium go the same way. So increased parathyroid hormone, increased calcium. So we can narrow this down to hyperparathyroidism as a cause of hypercalcemia. So again, hyperparathyroidism or an increase in the release of parathyroid hormone can cause hypercalcemia. So let's add in calcitonin. We remember again, calcitonin and calcium are inversely related. And when calcitonin goes down, serum calcium levels are going to go up. So when parathyroid levels are increased and calcitonin levels are decreased, we get hypercalcemia. Other causes of hypercalcemia can be bone cancer, so malignancies in our bone. When cancer invades our bones, it's going to take over that bone tissue, and that calcium that's stored in our bones is going to be released into our bloodstream, and that's going to cause hypercalcemia. Lastly, dehydration is a cause of hypercalcemia. So when our blood becomes too concentrated from not enough fluid, we can get hypercalcemia. Okay, so those are our causes. Let's now talk about what someone with hypercalcemia will look like, so our clinical features. So symptoms of hypercalcemia will start to occur at around 12 milligrams per deciliter or 3 millimoles per liter. So high levels of calcium are going to act like a diuretic with a sedative effect. So think high calcium, diuresis, and sedation. So high levels of calcium will pull water from our extracellular space into our intravascular space. So when the kidneys filter this blood, it can lead to polyuria and increased urination. And then polyuria is going to lead to dehydration, which is going to cause us to want to drink more or have polydipsia. So at regular levels of calcium, It's going to really regulate, calcium's kind of big job is regulating how our nerves and muscles function. So increased levels of serum calcium can lead to a sedative effect on nerves and muscles. So this is going to look like sedated nerves and muscles. So muscle weakness, paralysis, and decreased reflexes. We can also have decreased intestinal peristalsis. So remember, smooth muscles in our GI tract are muscles too. So those can be kind of sedated. But most importantly, think about our heart. Our heart is a muscle. So hypercalcemia can cause cardiac dysrhythmias like heart block and shortened ST segments. And most importantly, our brain is the muscle. So think a sedated brain. This can look like lethargy, confusion, stupor, even coma if levels are really, really high. All right, so again, hypercalcemia, it's going to act like a sedative. It's going to kind of bring us down, all muscles in our body. Okay, so let's talk about treatment. So as always, we have to get baseline levels and we have to monitor it as we're treating these clients. We have to know where we're starting to know where we're going. Another basic approach, we need to treat the cause of this hypercalcemia. So if we have high levels of parathyroid hormone, maybe we need to remove the parathyroid gland or have a parathyroidectomy. If it's bone cancer, we probably need radiation or chemotherapy. We also want to increase fluid intake to kind of dilute that concentration in our blood. This can be done through like oral rehydration or IV infusions of just like typical 0.9% sodium chloride or normal saline. We can also take medications that can kind of combat this, like bisphosphonates and calcitonin. So bisphosphonate will prevent bone breakdown and the release of calcium back into the blood, and calcitonin will increase the absorption of calcium back into the bones. So remember again, calcitonin has an inverse relationship with calcium. We also want to reduce or eliminate calcium-containing medications like calcium carbonate, which are like Tums, and thiazide diuretics. So again, thiazide diuretics are going to cause our kidneys to reabsorb calcium. So eliminating these will allow our kidneys to filter the calcium out instead. And again, since our heart is a muscle and it's having a sedative effect from the calcium on our nerves and our muscles, we want to monitor our heart for dysrhythmia. So that's going to look like continuous cardiac monitoring. And we're also going to want to frequently assess our client for changes in levels of consciousness. Again, think brain, think heart, think sedation. We're going to have to put in kind of foolproof monitoring to make sure we're headed in a positive direction. Okay. We're going to reverse things now and talk about hypocalcemia or low serum calcium levels. So decreased serum calcium level is a decreased serum calcium level less than 9 milligrams per deciliter or 2.25 millimoles per liter is what constitutes hypocalcemia. So causes of hypocalcemia are going to include conditions that cause decreased parathyroid hormone and increased calcitonin. Again, remember, parathyroid hormone and serum calcium move in the same direction, and calcitonin and calcium move in opposite directions. So decreased parathyroid hormone and increased calcitonin are causes of hypocalcemia. But what are these actually being caused from? So let's kind of get to the bottom of it. We can get low parathyroid hormone from a parathyroidectomy. So again, removing the parathyroid, removing too much of a parathyroid, removing too many parathyroids, all of that can contribute to it. A thyroidectomy can also be a cause of this. So when we remove the thyroid, those parathyroid glands are so small, they can kind of be like a incidental complication, like accidentally removing them, because we can't really tell the difference sometimes whenever the provider's in there doing surgery. And then anything too that might require radical neck surgery. So again, anytime those parathyroids are removed or damaged, that can be an issue for us. So other causes can be vitamin D deficiency. So again, the ingestion of vitamin D increases the amount of calcium that we absorb in our diet. So if we don't have enough vitamin D, we aren't going to absorb enough calcium. Then going back to our calcium pathway, it's absorbed in our GI tract. So conditions like celiac disease, which if it's not treated, it's going to inhibit how we're absorbing those essential nutrients and electrolytes into our diet. That can be a cause of hypocalcemia. And also lastly, conditions that can cause high phosphate levels. So this is where we're going to kind of talk about phosphate really quickly. So calcium and phosphate are always inversely related or always opposite. So phosphate binds with calcium and like sequesters it out of the bloodstream and into our tissues. So if you have high levels of phosphate, you're going to have low levels of calcium. So conditions that can cause high phosphate are things like chronic kidney disease and tumor lysis syndrome. And we talked on our electrolyte video about potassium, kind of what tumor lysis syndrome is. But think of those cancer cells again like balloons filled with confetti or glitter. And when treatment starts and those cells begin lysing or exploding, that's when all those electrolytes are going to seep into our bloodstream. So that can cause an increase of phosphorus into our blood. Okay, so those are that's a little bit more about causes of hypocalcemia or low calcium levels. So what is hypocalcemia going to look like in our client? It's the opposite of hypercalcemia. So calcium, we said, acts like a sedative. So when we have high serum calcium levels, we're going to have neuromuscularly sedated clients. But when we have low calcium levels, we're going to have neuromuscularly excitable clients. So nerves and muscles are going to be very irritable when serum calcium levels are low. So your client might have tetany, which is like peripheral neuromuscular excitability. They might also have a positive Chvosik sign. So a reminder about what that is, to assess for it, when you tap on the facial nerve right here, I don't know if I can do this with my cheek, but your cheek's going to like kind of twitch like that. I don't even want to know what that looked like on the camera, but it's gonna like go like this. So that's a positive Chvosik sign. You might also have a positive Trousseau sign. So this is when you apply a blood pressure cuff and you inflate it so that your systolic blood pressure is reading above what your baseline would be, and you're looking for a carpal spasm, which is like a twitchy or a glitchy thumb where your thumb goes in towards your wrist. So that's a positive Trousseau sign. So other findings might include like other paresthesias like tingling of your lips and fingers, hyperreflexia, so anything over 3+, so remember 2+ is our baseline, or muscle cramps. So just think twitchy, like glitchy, excitable neuromuscular functions. So again, remember our brain and our heart are also muscles. So an excitable brain might look like seizures, and an excitable heart might look like dysrhythmias, so like a prolonged ST segment. So again, we're worried about our GI system slowing down in hypercalcemia, but we're going to kind of put the GI system on the back burner for hypocalcemia, and we're going to focus on our respiratory system. So a glitchy, spastic respiratory system might look like laryngeal stridor, and that can lead to some respiratory depression as well. Okay, so treatment. We're almost done with calcium. Par for the course. We need our baseline information, our baseline labs. We're going to monitor this throughout our treatment. We're also going to need to replace calcium by giving IV calcium gluconate or calcium chloride. We're going to implement seizure precautions. Again, our brain is excitable. We're also going to collect an ECG and get some baseline cardiac imaging, and then put the client on continuous cardiac monitoring to make sure we don't have any fatal dysrhythmias heading our way. We're going to monitor respiratory status. Again, we're worried about that laryngeal stridor, so we want to make sure our respiratory status is good. And we also want to increase our intake of calcium-rich foods. So think dairy, leafy greens, fish, almonds, tofu, soy. So that's kind of calcium. Okay. Before we do magnesium, we're going to do a quick knowledge check. So I want you guys to hop in the chat, and I have one true-false question for you. So go ahead and drop your answers in. So true or false, calcium has a sedative effect on our muscles. True or false, calcium has a sedative effect on our muscles. Let's see. I should say increased calcium has a sedative effect on our muscles. Awesome. Oh my goodness, you guys have been doing so many great chats here. Awesome. Okay, let's see. Good job, you guys. Oh my goodness. Okay. There's so much. Okay, YouTube, Facebook, Instagram. Good job, you guys. So true. I'm seeing a lot of trues. I'm trying to click these as fast as I can. You guys are doing amazing. Good job. TikTok, hello. Good job. Okay, before a lot of truths. You guys got it. Way to go. Cool. Okay. All right. Oh my goodness. I am not fast enough for you guys. Good work. Okay. So this would be too a shout out to our friends on TikTok. If you haven't shared this video yet, please share. We're going to cover magnesium now, so it's not too late. Okay. We're going to jump into, so the answer, true. We have sedated muscles with hypercalcemia and excited muscles with hypocalcemia. Okay, we're almost there. Magnesium is a little bit quicker, not quite as involved as calcium, but a few notes about magnesium before we talk hyper and hypo. So normal range, 1.5 to 2.5 milliequivalents per liter, or 7.75 to 1.25 millimoles per liter. So hypermagnesemia is levels above 2.5, and then hypomagnesemia is levels below 1.5. So again, its primary role is really to aid in muscle function. So it works in the neuromuscular junction with acetylcholine. And what we need to know about acetylcholine is that it's essential for muscle contractions, including cardiac, skeletal, and smooth muscle contractions. Magnesium is also needed to make parathyroid hormones. So kind of reversing back to what we talked about for our hormones. If we have low magnesium, we're going to have low levels of parathyroid hormone. If we have low levels of parathyroid hormone, we're going to have low levels of calcium. So our manifestations of hypocalcemia and hypomagnesemia are going to mimic each other. So same with hypercalcemia and hypermagnesemia. Again, magnesium, this is a little bit different, but relates back in with our potassium. Magnesium and potassium move in the same direction. So if potassium levels increase, so do magnesium levels. And we're going to tie this in a little bit about when we talk about clinical features of magnesium, why this is important to remember. Okay, so let's talk about, we're going to start with hypermagnesemia, or increased serum magnesium levels. So causes of hypermagnesemia, or increased mag, include excessive intake of magnesium-containing medications like antacids or IV magnesium, which we give to treat preeclampsia in our pregnant clients. So we worry about mag toxicity or hypermagnesemia. Similar to hypercalcemia, impaired kidney function like chronic or acute kidney disease can also be a cause. So what is a client with hypermagnesemia going to look like? If we have too much mag, we're going to be too relaxed. So magnesium toxicity can range from mild to moderate to severe. So mild can look like nausea, flushing, headache, diminished deep tendon reflexes, or hyporeflexia. Moderate is going to look, again, a lot like hypercalcemia. So somnolence, absent deep tendon reflexes, worsening hypotension and bradycardia. So things are slowing down, they're getting sedated. Severe is going to be all our muscles are going to be way too relaxed, like in a very, very bad way. So that can be like flaccid quadriplegia. So think skeletal muscles. Respiratory failure, think about those lungs. And then cardiac arrest. Again, our heart's a muscle. We don't want our heart to be too relaxed. We need it to be just right. Okay, so treatment, par for the course, as we always say. Baseline information, monitor levels throughout. We're going to address the underlying cause of our hypermagnesemia, so reversing or removing magnesium from the body. So IV fluids like 0.9% sodium chloride or normal saline to dilute and wash out the blood. Calcium gluconate is also treatment for mag toxicity. So I thought long and hard about a good example for this, and I hope this is something that you guys will remember. And again, if not, it's okay. Okay, so picture this like a school dance. You have 10 magnesium, but you only have 5 calcium dancers. Okay, and they pair up. There's going to be 5 magnesium dancers that don't have a buddy, and it's going to bring the vibe down. So what we need to do is we need to give calcium. We need to bring the vibe up, and that's what the calcium is going to do. So they're going to work together. They're all going to make one great happy dance floor, and everything will kind of go back to normal. So again, calcium is going to bring the vibe up because magnesium is bringing the vibe down. So I don't know. I hope that works. Okay. Lastly, we want to avoid the intake of magnesium-rich foods like spinach, broccoli, avocados, potatoes, and whole grains, and magnesium-rich medications like antacids. We want to take those out. We might also need to just do dialysis. So if this is all related to kidney injury, we might need to do dialysis to remove that through a machine. And then we're always going to need continuous cardiac monitoring because our heart is going to be too relaxed. We need to watch out for things like heart block and asystole because, again, heart's a muscle. Okay, last one, hypomagnesemia or low magnesium levels. So causes of hypomagnesemia can include magnesium being too absorbed in the GI tract and eliminated by the kidney. So this can look like, again, malnutrition, chronic alcohol use. These are all causes of hypomagnesemia. GI losses from proton pump inhibitors or chronic laxative use. This is going to decrease the mag available for absorption in the intestines over time. Vomiting, diarrhea, malabsorption from irritable bowel syndrome. Renal losses can also cause hypomagnesemia, and those are caused by things like diuretics, especially with those are going to increase the excretion of magnesium through the kidneys. Antibiotics, like aminoglycosides and amphotericin, those are going to inhibit the reabsorption of mag in the kidneys. And then again, intracellular movement of magnesium. So if this is where we talk about potassium again. So in our potassium session, we talked about how insulin carries potassium into the cell, and we learned earlier that potassium and magnesium move in the same way. So if insulin is carrying potassium into the cell, it's also going to carry magnesium into the cell, and this can result in low levels of magnesium. And then again, we talked earlier about how magnesium is needed to make parathyroid hormone. So again, bringing it all together, if we have low levels of magnesium, we have low levels of parathyroid hormone. If we have low levels of parathyroid hormone, we have low levels of calcium. So the symptoms of hypomagnesemia are going to be the same as hypocalcemia. So our client with hypomagnesemia is going to have neuromuscular excitability, which is like that tetany, so that positive trousseau and Chavassic, so positive Chavassic on the cheek and positive trousseau in the arm with the thumb twitching this way. We're going to have muscle spasms and muscle cramps and hyperreflexia. So again, remember our brain and heart, those are muscles too. So an excitable brain makes us more likely to have a seizure, and an excitable heart makes us more likely to have dysrhythmias. So again, treatment for hypomagnesemia includes par for the course, baseline information, monitoring electrolytes throughout treatment. We're going to address the underlying cause, so administering magnesium supplements, oral or IV. We're going to increase magnesium-rich foods. So these are green vegetables, potatoes, whole grains, things like that. We're going to monitor our cardiac function, and we're going to address some of those GI and renal losses. So this can be things like treating nausea, vomiting, and diarrhea to prevent it from eliminating through our GI tract. We can also adjust our diuretics to be sure we're reabsorbing magnesium instead of excreting it. Okay, we did it. Calcium and magnesium. Just remember excitability and sedation. So we're going to bring up a question and see how you guys did. So I'm going to read the question to you guys. Feel free to answer in the chat. I'll give you guys some time, and then we'll walk through the question again, and we'll walk through the option choices. So we'll go ahead and pull up the question, and I will read it and then give you guys some time to answer. Okay, so the nurse is caring for a client with hyperparathyroidism who had a parathyroidectomy 4 hours ago. Which technique should the nurse use to check for complications in this client? Option 1, ask the client to place the backs of the hands against each other to provide hyperflexion of the wrist while the elbows remain flexed. Option 2, instruct the client to lie down and run the heel of one foot down the shin of the other leg. Option 3, perform the Romberg test by asking the client to stand with the eyes closed and the feet together. And option 4, place a blood pressure cuff on the client's arm, inflate to pressure greater than systolic blood pressure, and monitor for carpal spasm. So I will give you guys some time. Oh my goodness. Okay, you guys are answering quickly, and you are 100% correct. Way to go, you guys. So good. Good job, you guys. Good work. I cannot keep up with this. Good. I'm seeing a lot of Instagram, a lot of YouTube and Facebook, a lot of TikTok. Thank you for sharing, everyone. That's so great. Okay. Good job. Option 4. Good work, you guys. Okay. All right, so we'll walk through all these options, but kind of starting with the questions. So we see hyperparathyroidism. We know treatment for hyperparathyroidism can be parathyroidectomy. So parathyroid glands, again, are responsible for the production of parathyroid hormone, which is acts to increase serum calcium levels through the breakdown of bone tissue. So with the surgical removal of one or more of the parathyroid glands, parathyroid levels can decrease significantly again. So a significant reduction in parathyroid levels will decrease serum calcium levels, and that's going to cause hypocalcemia, which is, we can picture again as that neuromuscular excitability. Okay, so option one, the Phelan maneuver, which is what is being described, is used to diagnose carpal tunnel syndrome. So that's not going to be our correct answer. Option two, the heel to shin test, is what we use to assess cerebellar function. So again, that's not our right answer. Option three, the Romberg test, is kind of an element of neurological examinations that assess like our vestibular function. So kind of where our body perceives our head to be and where our brain perceives our body to be. So that's not our correct answer. But again, option four, we've talked about this. It's talking about the Trousseau sign, which again is what we would, how we would assess for hypocalcemia. So this is when we occlude the our brachial artery, and we're looking for that carpal spasm. So option four is your correct answer. So you guys did great. I hope this was helpful. As a reminder, we have our free 7-day trial on nursing.uworld.com. We hope you guys subscribe to all of our social media channels. We're at UWorld Nursing on all your favorite channels. We're on Facebook, YouTube, TikTok, Instagram. Come back on Thursday. We have another heavy-hitting electrolyte topic. We hope you guys will continue to subscribe, follow, like. We post a lot of content. We have a lot of great resources for you. But again, go to nursing.uworld.com. Check out our free 7-day trial. We know you won't regret it. We're here to help you. We want you to be successful. We want you to pass your NCLEX on your first try. So thank you guys so much. I hope that was great, and we'll see you on Thursday. Bye.